Right, we're now going to the last speaker. I'll just find the, and our topic is, just want to read it online. The story of LPA. Why are we concerned? And the person to answer that question is our distinguished Professor Iman El-Sherif from the Suez Canal University. Thank you for your...
Thanks, Professor Mike, for the nice introduction and welcome in Egypt. We are always delighted to have you on board. I'd like to thank Professor Ines Chaltout for inviting me to be part of this very distinguished scientific gathering. It's always an honor to be a part of ASD events. Dear Chairperson, dear colleagues, I wonder when last time you came across lipoprotein A among readings or you asked for it for your patients, other than the eminent professors who are seated here in this place. امتى آخر مرة فكرت إنك تقرأ عن الليبوبروتين A أو تطلبه العيان؟ Okay, that's the answer. Lipoprotein A had been always underestimated, maybe, though it's a cholesterol-rich, low-density lipoprotein. And a lot of studies had been made, we will come across them later, that unique about the lipoprotein A that it has a lipid core with triglycerides surrounded by a surface of layer of phospholipids. It has some sort of protein chains, glycoprotein chains around it called the kringles. Kringles have numbers 1 to 10. 1, it's there, and from 3 to 10. The number 2 is the one that's not there. Number 2 and number 4 may have changes all the time. That's why there are a lot of genetic variabilities regarding those lipoprotein A's. Anyone has any idea when it was first known about the lipoprotein A? It was as early as 1963 when it was the first time it has been recognized. A clinical observation had been shown to be there with coronary artery disease, and it had been known that the threshold is 30, but later 30 that had been recognized as one of the high risks. Normally it should be around 14 milligram per deciliter, and those from 14 to 30 milligram per deciliter is some sort of moderate risk. For those, we need to go for the coronary calcium calculations. And from 30 to 50, the maximum is 50. From 30 to 50, this is the high risk. The polymorphism, the isoforms, changes in the proteins of the kringles we had mentioned earlier is responsible for the different isoforms. A lot of studies had been there all the time, but one of the important landmarks is about 29. 29 is the first clinical, strongly study that had showed clinical relationship with the lipoprotein isoforms, and that's the turning point, which it had been known that the lipoprotein A is an independent and causal and genetic risk factor for cardiovascular risk disease, and the higher the risk ratio increases. The risk ratio increases when there is pointer options later. Here we can see that the hazard ratio, the risk ratio increases as there is more concentrations of the milligram per deciliters. I know these numbers are much higher, but this is some sorts of the logs calculations to increase the number so they can see it by the lab calculated. it has been found that there are more than 90% of lipoprotein A concentrations genetically determined. The main determinant is the apolipoprotein A polymorphism, والsingle nucleotide polymorphism في lipoprotein A هو المسؤول عن الجينيتيك ريجوليشن. هو started فين lipoprotein A started southern in Africa and it migrated up. It migrated from Northern America down to the Latin America, with estimates of lipoprotein A more than extremely elevated lipoprotein A above 50 milligrams per deciliter had been found mostly in the African Americans, while in others, Caucasians and other Asians, for example, they are lower risks or middle risks, or like lipoprotein A is as twice higher in African Americans in comparisons with Hispanics and others. Arabs have, Mediterraneans have higher levels, around more than 14, but still in the intermediate risk. A distribution of the concentrations, most of the people have around 30% have above 30 and 20% have above 50. This means that around 50%, half of the population are in the high risk group. The determinant static concentrations are according to the isoforms, the kringles. The numbers of the kringles repeats, the isoforms D, when they are more, the concentration is lower. When the kringles are higher in number, there is يعني it's inverse relationship. يعني ما kringles التغيرات دي تبقى تزيد تبقى الكونسنتريشن أقل والعكس صحيح. وعشان كده وجد إنه الكوبيز دي كل ما بتبقى الايزوفورم small isoforms كل ما تبقى أكتر فالكونسنتريشن بيبقى more، وده اللي هو in red والعكس in blue. ووجد كمان it had been shown that increasing lipoprotein A variants isoforms دي عندها very strong association with increased concentration and increased cardiovascular risk. On the contrary, those with decreasing genetic variants have low lipoprotein A, and that's why they have decreased risk for cardiovascular disease. Is it appreciated in هو lipoprotein A risk factor we don't seek? I think from the start of the day in the dyslipidemia and diabetes lecture by in whole B by Professor Fadi Azmi, and earlier in Professor Shauka's lecture and Professor Mek's lecture, there is all the time we came across the word the residual risk. The residual risk had been illustrated this morning about a case with LDL below 55, and still she developed myocardial infarction, maybe due to the other targets we are not seeking as the hypertriglyceridemia or the lipoprotein A. It had been classified as percentiles, and the most percentiles, above 95%, have the increased evidence of cardiovascular events. As the concentration increases more than 30 milligrams per deciliter, the risk increases. And it has been shown here that not the LDL concentrations only, but remnant cholesterol only, but also the lipoprotein concentrations more than 39 has a hazard ratio for myocardial infarction increase. So lipoprotein A has the highest risk than remnant cholesterol, and comparable to these graphs, you can see that it has the highest graph. Lifetime risk for major cardiovascular events increase with the levels. As it increases 150 milligrams per deciliter, the lifetime risk is about 0.40 in comparison with those who have lipoprotein A less than 30, the risk is less than 15. Other problems, related cardiac problems, can be there associated with lipoprotein A increased levels. Other than myocardial infarction, there is ischemic strokes, heart failure, and aortic valve stenosis. Not only this, but there is the accumulation, lipoprotein has increased accumulation in comparison with LDL in the arterial wall, and maybe more responsible for the plaques. And here comes the study which showed that lipoprotein A, the risk factor, even at very low LDL concentrations, the Odyssey outcomes, and this may interpret why the lady presented in a case this morning had developed myocardial infarction, though she was within the target of 55 milligram per deciliter LDL. That's why in 2022, the European Atherosclerosis Society had came to some key points, which are that LPA has a pro-inflammatory and pro-atherosclerotic properties, and that they should be, still there is some to be proven in vivo. And pro-inflammatories طبعا كان في in this morning Professor Amira and myself had shown the inflammation in relation to diabetes and had came through across all those inflammatory markers. Lipoprotein A had been shown that it increases the inflammatory markers. That's why it plays a role. It adds to the burden of the cardiovascular problems which are concerned with which are related to inflammation. Plasminogen activator, fibrinogen, platelet responsiveness are increased in the prothrombotic, and pro-atherogenic are increased with the lesion calcifications and the foam cell formations. That's why all the time from the start of 2000, after this landmark study in 2010, the European Atherosclerosis Society study group started to consider lipoprotein A in testing, and because of the possible unmet it's very important for the secondary prevention of patients with previous cardiovascular events, and it has been studied in a large Copenhagen general population study, around 2,500 patients, and had been shown that the least levels, the least evidence for cardiovascular events. And we have still time, but I want to go for a consensus about lipoprotein A, that it should be measured at least once in the lifetime of an adult, and its interpretation should be taken in context of the cardiovascular risk stratification. We all the time calculate for the LDL, ask for the triglycerides, but least likely we go for the more risk stratification, especially for those groups of patients who are in the not clearly high risk, in those between 14 and 30 milligrams, those for our the medium risk patients whom we are not sure to give statins or not. Specific LDL lowering therapies in phase 2 and 3 trials, yet are those drugs available in the market can be helpful regarding LDL levels. Maybe in old literature that I came across the notion of liver transplantation, which is not the case, because apolipoprotein A antisense, decreased hepatic apolipoprotein synthesis, has no effect on the LDL reduction, so, though it's very specific for the LPA lipoprotein A reduction. Still, we have good results on both sides for the lipoprotein A and LDL reduction, for example, by the PCSK9, 25% regarding the LPA, and 40 and to 60 almost percent in the LDL. Another drugs may be very helpful, yet statins are very weak regarding the LPA lipoprotein A reduction. That's why we are confronted with cases on statins and developing cardiovascular or events. Concentrations, risk of myocardial infarction in clinical practice had been shown here clearly that in familial hypercholesterolemia is very related, and that's why we have to screen for those with familial hypercholesterolemia or those with cases with premature cardiovascular death, first degree relative, we should do the lipoprotein A levels, and we have to consider that there may be other complications related to high lipoprotein A regarding, other than the myocardial infarction, regarding the peripheral artery disease, the stroke, the total cardiovascular mortality, heart failure, maybe, and aortic stenosis. These are there are lots to be studied. That's why studies are still needed. Concentration is under strict genetic control. We have to take good family history, and accumulating evidence is there for all ethnic groups, with a special consideration in the African Americans, and the relationship between lipoprotein A and atherosclerotic cardiovascular risk is continuous without any threshold effect. We have to consider its assessment once at life, once time at life, and it's a risk factor that's independent of the risk conferred by the LDL, and we had shown that many patients on statins target LDL within target, yet they developed another strokes. I hope I finished by time and came across the to the point, to the target. Thank you.